we'll go through ankle fractures real quick. I know there's a lot of slides on this, but don't worry, won't take too long to go through. So we'll look at a bunch of different fractures today. I think Katie, you may remember this one. I mean, even I'm no genius, but even I can figure out that this needs to be fixed sooner than later. And then we'll kind of talk a little bit about the thought process behind why did this one end up getting fixed here as well. Can you guys hear me? Everybody can hear me? We're good. So the ankle joint varies more weight per surface area than any other joint in our body. It can be prone to degenerative joint changes if there's any loss of contour or if we have chronic instability. And there's articles that show if you have 1 millimeter of shift of our talus within our ankle mortise, it can decrease the tibio-talar contact surface area by 42%. So essentially what this means is that the ankle can be prone pretty easily to developing arthritis. So in terms of the anatomy of the ankle, we know that the talus is wider anteriorly than it is posteriorly. So what does this mean? It means that the ankle is prone to injury if it's in a plantar flex position because that narrow portion of the talus is brought into the more centralized or front of the ankle. And it also means when we're getting when we have our x-rays, if we have these, non-weight bearing views with the narrow part of the talus in here, we don't quite appreciate the true contour of the ankle as opposed to a weight bearing view where we can see more of the natural outline of the talus fitting into the ankle mortise. Ligament structures, we have our lateral collateral ligaments. We have our deltoids, our superficial and deep deltoid ligaments. Our superficial deltoids resist eversion at the level of the ankle, but our deep deltoid ligaments are the strongest in the ankle, and they resist external rotation of the talus, especially in the setting of a fibular fracture. So if we have a fibular fracture and we have a rupture of our deep deltoid ligaments, that's when the ankle joint is unstable. We have our syndesmotic ligaments, our anterior inferior tib fib ligament, posterior inferior tib fib ligament, interosseous ligament, and inferior transverse ligament structures. In terms of the radiology of the ankle, I'm sure everyone's familiar with the basic X-ray structures, but we'll talk all the time when we're fixing these fractures, especially these comminuted fibular fractures, that what we want to see is that are we getting the fibula out to length? And really what we're looking at, or what we're describing with that is we want to see a parallel tibial and talar dome. We look at Shenton's line, which is this little notch in the fibula here. We want this to line up to our tibial plafond there. And we're also looking for a smooth contour, if you can picture that circle there, a smooth contour of our fibular attaching to our talar articulation below the ankle mortise. Just in terms of when to x-ray these, I think the most common criteria for when to x-ray an ankle injury are these Ottawa ankle rules. I'm not sure how often they're followed, but if a patient or an injured patient can't ambulate for up to 4 steps right after they get injured, or at the time of exam, if there's tenderness within 6 centimeters of the lateral malleolus, medial malleolus, fifth met base, navicular tuberosity, that's indications to x-ray these injured ankles. There's different classification systems for ankle fractures. We have our Danis-Weber classification. It looks at the relationship of the fibula to the syndesmosis. We have our type A below the syndesmosis, type B at the syndesmosis, type C above the syndesmosis. And then we have our log-Hansen, which looks at the position of the foot at time of injury, and also direction of force or motion through the talus in the ankle mortise at the time of injury. We can have a supination adduction injury, where we'll see this transverse fracture of the fibula and more of a vertical oblique fracture of the medial malleolus. These vertical fractures of the medial malleolus can involve a significant portion of our articular surface, which can make fixing a challenge. Talk a little bit about the fixation techniques for these as the lecture goes on, but another classification for log-Hansen is the pronation abduction injury, where we could see a rupture of the medial, fracture of the medial malleolus or a rupture of the deep deltoids, a syndesmotic injury, and then we have the short oblique fracture of the fibula at the level of the syndesmosis. Probably the most common injury are, are these supination external rotation injuries where we'll have rupture of our syndesmosis, this more classic spiral fracture of the fibula, rupture of the posterior syndesmosis, and a transverse medial malleolar fracture or deltoid ligament injury. And then we have our pronation external rotation, transverse fracture of the medial malleolus, rupture of the syndesmosis, this high fibular fracture, this Mason-New fracture, and rupture of the posterior syndesmosis. So goals with treating ankle fractures, we want to reduce the dislocations as soon as possible. That's probably the most important thing because we want to preserve our soft tissue envelope. All joint surfaces should be reduced precisely. Reduction of fragments should be maintained during the healing phase, and motion of the joints should be initiated as soon as possible. So I still don't know how this one wasn't open. I think this is a 90-year-old that came in here. So you can see the urgency with reducing this right away. I can't take credit for the reduction with this, or maybe I should. You guys would know anyway. But this was reduced fairly quickly in the OR, and then you can see as soon as fixing it later that day after clearance, we take the splint off and we can see just not really a soft tissue envelope that's conducive for fracture repair. So I think it's always important when we see these dislocations maybe to talk to the families about putting an XFix on, or at least have it on the consent form, the option to XFix it. So this was XFix for probably a couple of weeks before we ended up going back and plating her. But you can kind of see the soft tissue compromise that can occur fairly quickly with these dislocations. And you can see there too, obviously, just that medial skin is getting ready to necrose. So that's putting hardware through there or underneath that skin can be a nightmare after all is said and done. So additionally, we'll follow the principles of AO fixation, anatomic reduction, rigid and terminal fixation, atraumatic operating techniques, and early mobilization. So the surgical approaches for these fractures, there's the traditional lateral approach. It's not really the sural nerve that we're worried about with this incision per se. It's more the superficial perineal nerve. We can kind of get up in that region, especially with these more proximal fibular fractures, that the superficial perineal nerve starts coming through the coral fascia about 12 centimeters above the ankle mortise. So it's more, that nerve distribution that we're worried about with this. For fixing these lateral malleolus, we're typically looking at an interfrag screw for compression and a 1/3 tubular plate as a neutralization plate. Lateral plating typically, more traditionally, has been non-locking. We're getting bicortical screws above the fracture, unicortical screws, cancels in design below the fracture, so we make sure that we're unicortical there and we're not into the ankle mortise with that fixation. Posterior lateral approach, and with this approach we are concerned about the course of the sural nerve, but with the patient in a lateral decubitus position or prone, we can dissect in the interval between the perineal tendons and the FHL, and we can get access to the fibula and the posterior tibia as well. The advantages of posterior plating, we can oftentimes just put the plate on posteriorly, and we can avoid using live screws. The plate doesn't need to be contoured as well. We don't necessarily always have to put in distal screws, but the disadvantage of it is the potential perineal tendon irritation. Other forms of fixation, these hook plates work well for these more distal transverse fibular fractures. Locking plates do have indications for these fractures as well, these pre-contoured plates. I don't have a lot of experience putting in these IM fibular nails, but this is another point of fixation that can be used. I have put in more of these intermedullary screws. This was, I think, a 100-year-old patient that got transferred up to Jersey Shore from Soch with trimel fracture dislocation with a calcaneal fracture and a pretty poor soft tissue envelope. That I know this X-ray looks a little crazy, but I was able to get her to heal and walk on it. So that's another form of fixation that can be utilized. In terms of fixing these fibular fractures that are very osteoporotic, sometimes it's and this is the one I showed before with that looked like it had completely detached from the leg. When we're trying to get screws into these very distal fractures there, it's really not getting any purchase at all. So, and even more proximally too along the fibula. So, there's really nothing holding it together. So oftentimes what we'll do is we'll send these screws from the fibula, from the plate along the fibula into the tibia, even though there's not necessarily a syndesmotic injury, just trying to grab some bone in the tibia just to stabilize the ankle joint. Our medial malleolar incision for these fractures is vertical incision parallel to the axis of the tibia, and typically, if I'm looking right at the saphenous vein when I make the incision, and usually nicking it a little bit, that's when I know I'm right and bleeding everywhere. That's where I know I'm right where I need to be with that incision. So that typically the screws are placed parallel so that we don't lose our. If they cross, we can technically only have one point of fixation there, but we'll have the screws perpendicular to the fracture site, and we want to maintain a parallel orientation with fixation. So for these more vertical fractures of the medial malleolus, we want to try to get the screw parallel to the ankle joint as well. And plate fixation can be utilized to prevent dorsal translation of these fracture fragments, whether it's through this hook plate or through you could take a 1/3 tubular plate and bend it and contour it to the fibula. And here's just an example of some fully threaded screws, but it's traditionally more of a 4-0 cannulated screw, long or short thread based on the fracture pattern used for fixation. Posterior malleolar fractures, typically the rule of thumb is to fixate them if the fracture involves more than 25 to 30% of the joint line, if there's greater than a 2 millimeter articular step off, or if there's syndesmotic injury. Here's one where we had a more proximal fibular fracture, which you can see up here with some step off, really involving a huge portion of the articular surface, but definitely concern for syndesmotic injury with subsequent fixation and stability achieved in the ankle through a posterior malleolar fixation construct. Tightrope is something I haven't used often. I know a lot of docs do. It's a non-absorbable polyethylene cord that can be placed in. The advantages of using a tightrope are that you don't need a second surgery. It can be left in. It provides appropriate stability of the ankle mortise, but still allows for some diastasis. I know some guys will put in maybe a screw and a tightrope, and they'll remove the syndesmotic screw, but still have the tightrope in, which I do think does make sense. But it does offer the advantage of not having to go back in and doing a second surgery. Hardware removal for fractures should be left in place for at least 6 months and even up to a year, depending on location. It can take up to a full year for the bone to remodel around the hardware. Here's kind of what the bone will look like immediately after removing some of the fibular hardware there. So this is probably a talking point that's more near and dear to me. I think I probably see more of these than anybody else in the office. I don't know if the rule of thumb is if somebody has a bimal fracture or trimalleolar that ER keeps them, or if they have a fibular fracture, no matter how comminuted or displaced or shortened, they'll send it out. I'd probably say maybe about like 50% of the time. I don't know who's telling patients, but a lot of times they've already been told when they come to the office that they don't need surgery for their for this kind of ankle fracture. So usually I'm kind of working from a bad starting point already with this. But with these distal fibular fracture, these kind of more Weber B fractures, the goal of treatment is establish a congruent ankle joint, try to restore normal function. Essentially, what we're trying to determine is it just an isolated fibular fracture that we have, or is there a rupture of the deep deltoid ligament with this fracture pattern? So, and again, like we talked about before, the reason why we're so concerned about it, if you can have a millimeter of shift of your talus within your ankle mortise, it'll significantly decrease the contact area of the joint, creating a recipe for arthritis. So I would say here's one that clearly looks comminuted and shortened, would benefit from fixating, subsequently was. Here's one that looks displaced, and you can see widening of the medial clear space there, and subsequently fixed. But here's one not necessarily as obvious. So what I'll do if I see this fracture in the office, this isolated distal fibular fracture in the office, is I'll take them in and do what's called a stress examination. I'll take them back with the x-ray tech. I'll put their leg in a neutral position on the x-ray plate, and we'll internally rotate their leg about 10 degrees and put about 10 pounds of pressure to externally rotate the ankle. So it's important that we're not abducting the foot when we do this, but truly trying to externally rotate the ankle in this manner to see if this is the unstressed view, to see if there's any widening of the medial clear space. So what we're looking at is widening in through the joint surface here to determine if there's rupture of the deep deltoid ligament. So the medial clear space is measured from the lateral surface of the talus, the medial surface of the talus and the lateral portion of the distal tibia at the level of the talar dome. So if there's greater than about a 4 to 6, if there's more than a 4 to 6 millimeter space in there, that's indicative of the medial clear space being widened, and that's indicative of a deep deltoid injury, which creates an unstable ankle motor. So the problem would be if we had this patient, if we treated this with a walking boot, essentially the patient's ankle would be replicating this motion as they walked on it, creating arthritis. So this is that black line represents that measurement of that medial clear space. So if we have that fibular fracture there, widened medial clear space, that's a bimalleolar equivalent ankle fracture that we would typically recommend surgery for. So here's another one. I think that fibular fracture you could justify as maybe short and comminuted enough to fix, but just another stress X-ray where you can see the instability created with if they were weight bearing on this. So the disadvantage of a stress exam: radiation exposure to the patient. It's painful to the patient. It's time consuming. We're not necessarily evaluating the ankle in a plantar grade position. Leaves room for variability in how hard we're stressing when we test for this. Other ways to try to determine if we have a deltoid injury, I think this would technically make sense. Do they have pain, bruising, and swelling over the deltoids, or versus not having? I think you would think if you had a lot of bruising there and swelling that you may more likely than not have a deltoid injury, but there have been studies that show in patients with no bruising or pain there, positive stress X-rays. Gravity stress views you can take. That's another option to just try to see if the ankle appears unstable, indicating deltoid injury. Weight-bearing X-rays, I think that would, in theory, make sense too. If you let the patient stand on it for an X-ray and the ankle looks completely stable, then they should be fine to walk in it. So, but here's a case where this is a lady in her 80s that came in a few years ago, where kind of vague injury history, had her take a weight-bearing X-ray, and you could see the fibular fracture here. I thought everything looked stable, didn't want to make a big deal of it. You can see the fibular fracture on the lateral view too. Let her started walking on it in a boot. She came back 2 weeks later, and you can see that I missed all this here, the medial malleolar fracture. You could see the posterior mallet fracture here. So it was a good thing she came back, I think, a week or two later for follow-up. But on the CAT scan, you can see quite a bit of the extent of the injury that was missed just with these getting these weight-bearing views in the office. And thankfully, she did well, but pretty big difference from just telling her she needed a boot for treatment. Alternative testing to work up a deep deltoid injury. Ultrasound can be utilized. Not often. MRI is another study that can be, you would think would give us a lot of information about the integrity of these deltoid ligaments, but just not quite often used. Here's an example of a fibular fracture that was stressed in the office, and we can see that the mortise is still intact there. So this was treated with a boot. Here's one I would say is a questionable stress fibular fracture. I'm not quite sure if this clear space is wide enough to justify plating, justify taking to surgery. So in that instance, it's certainly appropriate where we could cast these patients. So if we're worried about the talus shifting or the fibula displacing, but we have appropriate alignment with X-rays, they could always it's a judgment call, but you could always cast them and just keep them off it. And that's how this patient looked with weight-bearing X-rays down the road. So last thing we'll kind of talk about is a syndesmotic injury, as it relates to these Weber B fractures. So the rule of thumb for many years was this critical zone. So if you had a fibular fracture in the setting of a ruptured deltoid, if the fracture started 3 to 4.5 centimeters above the ankle joint, then you needed to address the fibular fracture, but also put in syndesmotic screws to account for the disruption of these ligaments. But this has kind of been, this thought process has been changed over time. So this would be a Weber B fracture that was plated, and you would think that the syndesmosis in here would still be intact because the fracture was closer to the ankle joint. But you can see with stressing these, even after plating these lower fibular fractures, you can still see widening of the medial clear space and disruption of our syndesmosis. So this study here looked at about 240 cases of these fracture patterns and saw in about 40% of the time there was still a syndesmotic injury that needed to be addressed. So the rationale for this essentially is probably the degree of rotation that's involved with these fracture patterns. Indications for syndesmotic screws, again, are this persistent widening of the medial clear space and disruption of the hip-fib articulation just above the ankle joint. You can do this hook test in the OR after you plate the fibula to see if the syndesmosis is loose or disrupted. And we can do that cotton test or that external rotation stress test that we did in the office to determine if the syndesmosis is disrupted. There's no consensus regarding how many of these syndesmotic screws do we put in. Do we grab the far cortices here? Do we put in 1 screw, 2 screws? Do we put in a tight rope? Do we leave these screws in? Do we take them out? So it really is surgeon preference in terms of treating these. But when we put them in, we do want to clamp across the syndesmosis to maintain reduction. Hold the foot in a neutral, slightly dorsiflex position. And we want to angle obliquely 25 to 30 degrees to capture the tibia with these screws, because we know that the fibula sits a little bit behind the tibia at the level of the ankle joint. So here's just some cases we'll look at. We could see a very low distal fibular fracture, disruption of the ankle mortise. And even after plating the fibula, you can see that the ankle is still very unstable, requiring the placement of this syndesmotic screw here. And you can just kind of see, the level of instability that would still technically be present within the ankle joint after fixing this fracture if the syndesmotic screws weren't placed. Here, just kind of appreciate how open how much of a stress you can get through these joints if you don't address the underlying ligament injury. So just in summary, post-op care for a non-syndesmotic injury, I'll typically have patients off their foot for 4 to 6 weeks after, remove the sutures 2 to 3 weeks, short leg cast, transition into a boot, lace up brace, and then therapy. For syndesmotic injury, I left it out, but I'll leave them non-weight bearing for about 6 weeks. Again, suture removal 2 to 3 weeks after surgery, short cast, transition into a boot. And I'll typically take my syndesmotic screws out around 12 weeks after, and then have the patient start PT. So here's just a couple of cases where, even recently, where I didn't take out the syndesmotic screws. This lady came back 2 years later, and they were starting to back out there. And this is how they'll look if you leave them in on the right there. They usually will break. It's not necessarily a problem per se unless the patient has pain, but it can be tough fishing those syndesmotic screws out after. Additional injuries. This is just a picture of that first ankle fracture dislocation that I showed you guys. I actually couldn't get it reduced. It was really embarrassing. Katie was there. She can account for that. But the reason why I couldn't get it reduced was actually the medial malleolar, the posterior tibial tendon had been entrapped in the ankle joint here. So you can see almost complete severance of that, and that was blocking my reduction in the ER. So I had to repair that at the time of injury. And this is also a trimal fracture that came in fixing the medial mal. You could notice that there was a pretty significant injury to the talar dome that I was able to just kind of microfracture with a dental pick at the time of fixing the medial fracture. And then he also had a syndesmotic injury, taking him back about 12 weeks after. Just put a scope in there just to see kind of how the dome looked after the injury, and was able to microfracture it again just to see if we could improve his outcome long term. I think these talar dome injuries happen often, but I'm not quite sure 100% how symptomatic they are. Based on the level of the location. I think with this guy, I just decided to put a scope back in there and take a look at how it was doing, just because it was so obvious when we fixed his medial malleolar fracture that he had it. So I thought maybe just trying to clean him out or microfracture him again might give him a better. That's it.
Got a lot of questions for you.
All right, fire away.
More discussion points than anything.
Sure.
Kind of brain a little bit just because I've done a few of these recently down in Southern New Jersey, so I'm like, thinking about delayed management. First of all, why do you use that cast as an intermediary step after you do an ORAF? So when you say you do the ORAF, splint them, then cast them, then boot them. What's the advantage of the cast as opposed to just allowing them to start some range of motion and prevent atrophy?
I mean, you could put him right into a boot. I guess I'd like to see him non-weight bearing for, get him to about that 4 to 6 week mark before I let him start putting weight on it.
Do you think that they're more inclined to put weight on it if they're in a boot as opposed to in a cast?
Yeah, I think once they go into a boot, they're walking on it. I think, it's almost impossible for the patients, at least that I see, to stay off their boots.
And why is that? Is the boot heavier?
I think the boot's heavier. I think it's more awkward than the cast. I think the cast is pretty form-fitting so that their patients are usually, from what I see, a lot more compliant with non-weight bearing with being short leg cast. I think once they're in the boot, they're definitely they're taking it off. They're probably walking on it without anything.
Right.
But I think it's probably just the safer play to put them in a. So I'll do this for bimalleolar fractures and trimalleolar fractures. If I just was fixing the fibular fracture and it was completely, and there wasn't a syndesmotic injury and I took the stitches out, I would put that patient in a boot. I should probably let him start weight bearing on it.
So the bimal equivalents you would do?
I would cast them. I would cast those, the bimal equivalents, the bimals, and the trimalleolar fractures. I would cast them for a few weeks after. And then around the 6 week mark, let them start weight bearing.
He does a lot of casting afterwards. Partly, like you were saying, don't trust them.
Yeah.
And then plus the cast box compression.
Yeah, exactly.
I just wonder if you're putting them, it's a balance, right? Because you're probably doing a longer PT rehab afterwards.
Yeah. I think, though, a year after the surgery, I think they're the same. Yeah, I think they're the same. I think that I just feel a little bit better kind of just making sure we're completely healed before I let them weight bear on it. But I know plenty of docs that are probably just putting them in boot after. So I don't think
long boot versus short boot. Is there a difference?
Definitely long boot.
Okay.
Definitely long boot.
When is the short boot?
I only use the short boot for like metatarsal fractures, not like Liz Frank injuries, metatarsal fractures and distal. So, like for
and why is that? Just more stress reduction?
Yeah, I think that. Yeah, you can mobilize all the muscle structures above the boot. I think that. I think the shorter boot is really just kind of barely coming above the ankle, and you're not getting any ability there. I think with that longer boot, the way the straps come up, grab those muscles above there. I think that you're definitely immobilizing the ankle as opposed to that shorter boot. Really, even like for posterior tib tendonitis, you should probably use a taller boot. That short boot, I'll really only use for metatarsal fractures or like multiple digital fractures. But that's it.
Has long leg casting, and this goes back
right.
to long leg casting for bimal equivalent fracture. Is there still a role for that?
I think there is, and they kind of. I remember talking to Nietzsche about this a bunch when we were first starting. Like if I'm worried that they're going to like walk on it and shift the ankle, we should just put them in a long leg cast. But I haven't really done it a lot lately, but probably should do more of them. But I'm just putting in a below knee cast for all these patients.
Or the fibular fracture cases.
Any of the casts I'm putting on, I'm usually just putting on below knee cast. But if we're really truly concerned someone's going to walk on it.
Right, but if you do, so you see that fibular fracture, it's like a millimeter placement. You go and you do your stress view, and it opens up. So now you have an unstable angle, right? So my question there is, can you just treat this patient conservatively in a cast, right? I mean, in a short leg cast. The disadvantage of that is they may walk on it and displace it. Right. So are you safer with a long leg cast, which you flex the knee so they're very unlikely to put weight on it? Right. Or do you just say, look, I don't want to take any chances. That's somebody I'm just fixing. Just put a fibular plate on and be done with it. Right.
It depends on the patient. Depends on how unstable it is in the stress. I worry too if the stress is grossly unstable. They have a syndesmotic injury too. That can be addressed at the time of surgery. So if they have a syndesmotic injury and we're treating it conservatively, how long are we keeping them off it? Do I keep them non-weight bearing for 12 weeks in a in a above knee cast.
You can't do that.
Right. So it would depend on the patient's age, the level of disruption we'd see on the stress X-ray. But yeah, I think that there probably is a bigger role for maybe treating conservatively with casting. And then if you're worried about their walk on it, then it's a long leg cast. So it's
you guys see that much? No, Greece.
Right. That's the thing too. It's there's a lot I haven't fixed where patients are complaining for a long time about how much it hurts. And, maybe we would have done better if I just played it and got a move on it right away. So it's balance.
These stable fibular fractures, how soon that you put in the boot, you see them, you analyze them, they don't open. How soon do you think they actually start walking on? And I'm just thinking in terms of disability and then what do you do about them driving if it's their right foot?
For driving, I basically tell them for these fibular fractures, don't drive with your boot on. Okay, right. Put your sneaker on or sandal or whatever. And I'll say when you physically feel comfortable that you could slam on the brakes, you're not going to do any harm to your ankle, but that you feel that you can physically do it, then it's okay to drive. So if you don't feel that
is on average, 3 weeks?
No, probably within a few days. I think.
Really?
I think so. Yeah, I think patients are pretty motivated to drive.
Okay.
For the most part. The only issue per se when I see it are for workers' comp patients. So all of a sudden, I had to get a chauffeur to take me to work, and that's when it becomes more of an issue. But I think patients are usually pretty motivated.
And you think they're walking on these very quickly. Back to your other point that it's very hard to be non-weight-bearing in a walking.
Yeah. For the most part, everybody's back. If I'm following up with these within a week or two, just to make sure, like that older lady that X-ray I showed of that older patient where it fell apart. If I'm having him check back in a week or two, just make sure I didn't maybe miss any other fractures. For the most part, everyone's walking in. It's back. Still using their crutches or a walker.
I feel like people want to get rid of that boot fast as well
because
it throws off their balance.
Sure.
And bothers their back.
Yeah, everybody hates it.
Oh, there's a big right.
It's not comfortable.
No.
What's that?
It's not comfortable.
Yeah.
No.
He makes a good point. We almost should put like a heel lift on the opposite side.
They have those. Yeah.
Right.
Even up or step up. They sell them.
Right.
Some patients get them. Not a ton.
Yeah.
They do sell those.
Maybe if someone had like lumbar problems, pre-injury or something, that would be
right.
Because we see that occasionally. Someone's got that boot.
Yeah, it's easy for me though. I just tell them I can't treat that.
Right.
Send
Exactly.
Ray or counteract.
Which ones do you want to do?
That's a good question. Yeah, I mean, if for those obvious fibular fractures where the medial clear space is disrupted, it's probably easier. It's just tough sometimes to get. The patients can't walk, so they're on crutches, and let's say I need them to they're older, they have to go get their cardiac clearance, and they have to, maybe they have other issues, pulmonary clearance or general medical clearance. It's a little bit tough as an out, especially if they need cardiac clearance. It's a little tough to try to coordinate a lot of these things outpatient wise. But yeah, I would say if the motorist definitely looks disrupted, it might just be easier to keep them here because we would fix the bimel or trimel, right?
Yeah. Well, I mean, two things. I think you make a good point about the medical. Probably ask that, and if they're a sick old person. But just logistically, it's a lot easier to put this on your day, on a Tuesday or Friday, and just get it done as an outpatient. Yeah. Than having to wait and go on the add-on schedule.
No, that's true too. Yeah, it's about definitely it's a balance of. It's hard to tell all the issues patients are getting around or getting rides, getting them here, and the availability of the schedule. Yeah. Right.
And then what you're going to do is tell them to come back to the ER so you could do it at the end of the day. So that one you bring in.
Right.
Medical mess.
Yeah. You're trying to get everything all situated for them. It's easier just to do it through the ER.
Yeah.
They show up,
Or they try, but because they have no insurance.
Yeah.
What does that look like?
That's Cincy's, yeah.
Okay.
Yeah, I know.
And is that a special order, or is that in the
No, it's not in the small frac. I think Chris always brings it in. I guess technically special work.
One thing from our residency, and what Green does too, is that our guy who did trauma and then foot and ankle was very cost conscious, and he said the 4-0 cannulated screws, that's like an extra like $500 a cost because of the cannulated drill bit is very expensive, and we can't bill that.
Yeah.
So we're always taught to do 4-0 cannulated screws, but not the cannulated, just regular screws, and then we'll put 2 drill bits in, do 1 drill bit, leave it, and then put the second one behind it, and you can assess them both on X-ray, and then take the drill bits out and do it that way.
Okay.
I mean, that's just another thought. I don't know if you ever taught that or
no,
whatever.
It makes sense though.
Do you guys use cannulated or you do? Okay. So maybe that's just a Robert Wood thing. Yes.
Yeah.
You remember that?
Yeah.
Right. That's good. And then what about when you remove the hardware? Do you have to restrict your weight there?
I don't. Lately, I'll take the hardware out. I'll just put a bandage around their ankle just to cover up the incision.
Yeah.
I'll just let them walk in a surgical shoe at that point. It's usually about 12. We're past 12 weeks usually with removing it. And then I've been having them come back into the office like a week later just to check the incision. Even put like a tegaderm or a permapore over it. It's usually a small incision. And they'll even start showering and moving on it, get back to normal. And then I'll take the stitches out and have them start therapy. So even get the bandage off pretty quick lately.
How long are they usually in therapy after?
I always insist that they do a little bit. I've had some patients go for at least 6 weeks. I think most people are pretty motivated to at least do a couple sessions. Depends on their age, their work commitments, their co-pays, type of stuff. But usually some people do some.
These do well. It's a nice win because they look so awful when they come in and then.
Yeah. No, they're definitely my favorite things to do. Yeah, for the most part, people do. That's in osmosis stuff makes sense. I know it's a little.
I know Green does a lot of tight ropes.
Yeah.
The second tight rope when he takes the screw out, so it might be a little more aggressive.
Yeah, where I trained, we were using. It had just kind of come out. I actually did more. People were using them for bunions when I first started. So if you could reduce if I had a flexible foot, you could reduce the bunion. I had attendings that were just putting those in and kind of pulling the foot together, and they were like so happy about it because they weren't making osteotomies. And then we had one attendant that did a bunch of them. Then we saw all these like second bed stress fractures, and so he never put them in. And then I put them in a few times for Liz Frank. But at the time, the main attending I was working with for trauma, Fleming, wasn't doing them for syndesmosis. So he was really advocating screws. So that's just always what I did. But I mean, I see the benefit of not having to go back in and fish out those syndesmosis. But
and it's interesting. You showed the picture where you had only 3 cortices and they broke. Because usually I would think that the 3 is going to windshield wiper, but you can't sell his phone. But that was interesting.
Yeah, it broke. Yeah, and that other lady, they came in, they backed out. I have a lot of trouble telling patients too, like even if they do break, like they see their X-rays like 4 months out, 6 months out, whatever, that the screws broke. Like, no, it's fine. It doesn't hurt because those broken screws are in there. It's fine. Trust me. Like, nobody believes me, but so I think.
They want to help.
Yeah. Like, I've broken screws in my leg. What do you like? You kind of lose some trust in what you're telling them. Don't worry, it's fine. But another reason to take them out.
And 6 weeks after syndesmosis, they can start carrying weight on.
I've been letting them.
I've been pushing a little bit.
Yeah, I guess I'm getting lazy. I'm tired of it. But I've been letting them start putting some weight on around 6 weeks in a boot. But just tell them, careful.
Whatever that means.
Yeah, whatever that means. Yeah.
Any thoughts? Okay. Good. Thank you.
Yeah, no problem. That's.
Thank you.
Don't record it. Oh, okay. I can say whatever I want. Yeah.